You're watching CTOM TV. Knowledge is power.
Multiple myeloma is a disease of white blood cells also, and it's they're referred to as the plasma cells. And what these cells do is they produce antibodies.
Okay. You mean when they're working properly?
When they're working properly,
okay.
Yes. Yeah. And so they're located in the bone for part of the life anyways. And what happens is when you get a mutation in the genes that produce these cells, what they do is they don't develop properly. And so number one, they're stuck in a stem cell like program where they're constantly reproducing. But they're constantly reproducing cells that can't produce proper antibodies. So they produce non-working antibodies. So all of a sudden you've got this mass amount of cells overcrowding the system, and they're also not doing their job. So you obviously have a lot of side effects, such as your immune system's not going to function properly, and you'll be susceptible to a lot of other diseases and other conditions.
If these antibodies or the white blood cells are located in the bone, does that mean that multiple myeloma is a disease of the bone?
To a certain degree, yes. That's where they find the cells and do the testing.
Okay, what else?
So multiple myeloma can be a slow-growing disease, or it can be a fast-growing disease. And the decision of when to treat is probably the most fundamental issue in multiple myeloma right now. In other words, what do you do? When do you treat? Should you treat right away? Should you treat later? Some patients we have been, they've had what they call smoldering multiple myeloma. They've had that for many years and it's never progressed. They've been able to keep it in check with lifestyle. Lifestyle is a huge factor in smoldering multiple myeloma. There's a lot you can do. You want to get a lot of exercise. You want to clear out your system. You want to, really take good care of yourself.
Okay.
So smoldering multiple myeloma is the big issue. And so they have this protocol that they've been using for a long time called CRAB. And that refers to increased calcium, renal failure, which is your kidneys, anemia, and then bone lesions. So when you start having an increase in these, then they start treating you. And the typical treatments have varied over the years. And the goal is obviously to get a stem cell transplant. And that's one of the best ways of treating most of these diseases.
Is there some reason why they just wouldn't start with that? I mean, aside from cost, if we took money out of the factor.
There's many reasons. They do try to start with that, but in order to get to a place where your body will respond to that, you have to have your tumor burden down very low. And that's the key.
And so the lifestyle.
And they can tell a lot too by how well you're going to respond to a stem cell transplant, by how well you respond to your initial chemotherapy. And that's kind of the goal of that.
So everybody starts on standard chemotherapy? Is that what you're saying? That's kind of the standard care?
That's kind of the standard, yeah.
Okay, and then if you respond well...
Right.
Okay.
Right. So recently, as of 2018, the Mayo Clinic came out with a wonderful new protocol for determining when to treat people. So the CRAB protocol is to try to determine when to treat someone with smoldering multiple myeloma.
Okay.
So the CRAB protocol obviously does not take into account certain things like high risk. And high risk are, genetic features. So high risk patients, genetic features such as, let's see, I wrote some of these down. So the translocation of chromosome 4, it's called the 414, deletion of the 17p chromosome, or a gain of a 1q. And each of those are high-risk genetic factors. So you want to know that.
Can you repeat those?
So it's a 414
translocation,
a 17p deletion, or a 1q gain. And so the p and the q are just different arms of each chromosome.
I see. Okay.
So each one of those, if you have smoldering multiple myeloma and you have one of these, then you're going to be in the high risk category.
Okay.
And that means you have a really good chance of not staying in smoldering for very long. You're going to progress quickly, and you're not going to respond well to treatments. So
are we still talking standard treatments? Are you about to tell us, wait, there's more? Or is this
we're not there yet.
Okay, all right.
So once again, we're at smoldering.
All right.
And when to treat and why to treat. So that is the problem with crab, is it doesn't take into account the high risk genetic features.
Right.
And so you have to get a genetic sequencing for that, cytogenetics. So then the Mayo Clinic in 2018 came up with a wonderful new protocol. They call it the 20-20-20, or it's actually 22-20. What that refers to is a bone marrow plasma of 20% or more, an M protein, which is a protein that's used in diagnostics of multiple myeloma, an M protein spike of greater than 2 grams a deciliter, and then a free light chain ratio of greater than 20.
Okay.
So those are the new criteria for high risk in multiple myeloma when you have a smoldering situation.
So they still do the crab thing, but they also do this.
Yeah, this is kind of determining. This is in addition to the crab.
Okay.
So this helps if you're following the crab protocol or the crab diagnostics. Then you want to include the this 22-20.
Got it.
Because it will allow you to determine, which one of these patients are high risk and which should be treated quicker.
Which could also be determined by the genetic testing?
Yes,
or?
genetic testing,
Okay.
yes. So the big thing over the years, and we've been advocating for this for a long time, we believe that treating high-risk smoldering multiple myeloma patients is the best way to go. And, a lot of doctors have been very reluctant to do so, just because they don't necessarily grasp the concept of what's high risk and what's low risk, and what the benefits are. And so now we have some great studies that show that adding do you recall thalidomide?
Yes.
We discussed it. So it also plays a great role in multiple myeloma as well as lymphomas. And so the way it works is the thalidomide class of drugs, and there's actually 3 of them now. They've changed them and they've adapted them so they're more specific to cancers. There's lenalidomide, there's thalidomide, which is the original one. Lenalidomide was the next alteration of it, the 2nd generation version of it. And then there's pomalidomide, which is the 3rd generation version. So the way these drugs work is they inhibit a process called angiogenesis. And angiogenesis is the mechanism that cancer cells use to recruit blood vessels to grow and metastasize quicker. Because they're so highly metabolic, they need to have a really good blood vessel system. Unfortunately, with angiogenesis, it's not a complete development of a blood vessel system, and they miss, I think, the 7th or the 8th stage of blood vessel development from neogenesis. So as a consequence, you end up with leaky blood vessels. Sealing of the blood vessels is one of the last stages in the development of a new blood vessel. And in angiogenesis, you have kind of leaky blood vessels, and that really helps the tumors grow and metastasize.
So the thalidomide and the other 2 help to stop.
They inhibit angiogenesis.
Got it.
And that is probably part of the mechanism of why they cause birth defects too. Is they probably inhibit the processes involved in growth and development.
Yeah, it makes good sense.
Yes. So while it doesn't work for pregnant women, it seems to work quite well for cancer. And so they also work. They also increase these drugs called interferon, or these molecules called interferons. And the ones they interfere with is interferon gammas. They increase interferon gamma 2, 10, and then they downregulate 6, I believe it is.
And what does that mean?
These are just pathways that cancers use
I
to grow
see.
and metastasize. So they actually have some specific cancer pathway effects, as well as inhibiting angiogenesis.
Wow, that's actually
So to circle back with smoldering multiple myeloma, we found that there's a recent study that shows that if you have smoldering multiple myeloma and you take lenalidomide while you're smoldering, in other words, treating before you actually have full-blown disease, you get a 78% risk reduction, which is huge. So, we've been advocating for treating smoldering for many, many years. The data has been shaky. It's been hard to determine who to treat, but it's just a common sense thing. You treat the disease at an early stage before it gets its heterogeneity. You're going to have a much better, much longer lasting effect. So rather than waiting until you have full-blown disease to treat it with targeted therapies at an early stage, and then rely on chemo at a later stage. So in the beauty of this study of adding lenalidomide and dexamethasone, the beauty of this is it works better in high-risk patients. So those high-risk patients that we were just discussing, so they have a 90% reduction in death and disease.
Whoa!
Yeah, so that's pretty significant.
Yeah, let's talk about that. I feel like I missed something in there. You mentioned Dex something or other.
It's just a steroid that's normally used.
A steroid, and that helps with the interferon somehow, or what? What does that do?
No, that helps with the lenalidomide. It's dexamethasone is used in treatment. It was one of the first treatments for multiple myeloma.
So
it's just a steroid. It's not really considered a cancer-fighting treatment. It's more of something that deals with the side effects of cancer, but also in that process, it reduces the overall progression of the cancer.
So let me make sure I'm following you here. If you are a multiple myeloma patient or smoldering multiple myeloma patient, and you have some of those high-risk factors that you talked about.
And even if you don't.
Even if you don't, you're 78%.
Yes, risk reduction.
And
progression.
Yeah. And 90% of you do.
Yeah.
So that it's actually kind of becoming a good thing to have some of those high-risk factors in some twisted way?
In some twisted way, yes.
Wow.
And so, you may want to ask what the risk is for progression.
You mean your personal risk based on those factors?
So if you have, low-risk disease, you have, I think it's about a 5% risk of progressing within 2 years. If you have intermediate, it jumps up to about 17 to 20% risk over 2 years. And if you have high risk, you have at least 45 to 50% chance of disease progression in 2 years.
So either way, if you can make a sound argument for early treatment rather than watch and wait, the percentage of likelihood of success of treatment or longer life is 78%
it's
to 90%.
Pretty significant, yeah.
That's outrageous.
And there was another trial on that too. This focused on high-risk patients, and it based the high risk on the Mayo protocol that we said, the 2020. They use that as a guide, and that's kind of where they developed it. It's called the Q-Redux trial. And so it was just for high risk. And they found that in patients, when they gave them this lenalidomide and dexamethasone combination, for these high-risk patients with smoldering, the progression was not reached in the trial versus 23 months in the non-treated patients.
For those at home, what does progression not reached mean?
Well, when you're in smoldering, when you get the progression of the disease.
So it means you haven't even started to show disease then.
No,
or it's not
you
growing.
have the disease. It's called smoldering.
Okay, so it's there.
Yes.
Doesn't the treatment take it away?
Yes. I'm not sure I understand what you're getting at.
Neither do I. So what you were saying is there's this certain, if you could just say it again for what you were saying, the smoldering, the progression, the reduction.
So when you have smoldering multiple myeloma, you have if you have low risk, then you have a 5% risk increase in 2 years.
Got it.
If you have intermediate disease, you have a 17 to 20% risk. And if you have high risk disease, you have a very high chance of progressing within 2 years. And so that means that, you're not going to have a good outcome if you have high risk.
Okay.
So when they took this group of patients with high risk and they gave them this Lendex, rather than not giving them any treatment whatsoever, the progression was not reached in the Lendex in the first period of time versus 23 months in those that did not get the disease.
Okay.
Did not have the treatment.
So standard might be 23 months then. And by the time 23 months passed, these people hadn't progressed.
Exactly.
Okay, thank you. That's what I was trying to understand there. Okay. And that was with what treatment?
That was with the Lendex.
Okay. All right. Wow. So that's pretty exciting. And how long have these things been around? Like, when was this study that had those numbers? 78% for low risk, 90% for high risk?
Well, they haven't focused on smoldering, and that's the problem.
Oh.
That's the whole thing.
Because they're not really thinking.
Well, they don't
of it
understand
as,
the risk factors, and that's what we discussed in the beginning of this conversation. Is
it.
smoldering was the big issue, and having that, deciding when to treat these patients is really what it's all about.
Got it.
And should they be treated or not?
So the genetic testing to see if you're in
High
any
risk.
of those 3 high risk categories,
or the
20.
20.
Yeah, got it. So you want to make sure that those options, or you're getting that kind of diagnostics as well as the crab.
Exactly. Yes.
Okay.
So the crab is not enough.
Yeah. Okay. That's the fundamental point, I guess, that you're trying to make.
Yes.
If your doctors deciding on treatment based on crab alone, no.
No. So, it's important to speak with your doctor and make sure they're following, this new criteria, 2020 from the Mayo Clinic. Yeah.
Yes. Okay.
Yeah, and that they are looking at genetics.
Yes.
And they have really defined whether you're high risk, low risk, on genetic basis. That's so important.
Because 90%.
And then why not get treated, even if you're low risk? Why not?
Exactly.
With such a reduction, the side effects are minimal. So now we're going to get into the actual treatments. So when we first started treating multiple myeloma, there was a class of drugs called proteasome inhibitors, and they really made a big difference in treatment. Fairly old drugs. The first one was bortezomib, and that was combined with cyclophosphamide, which is a very old drug, and once again dexamethasone. So pretty well every multiple myeloma protocol is going to include dexamethasone. It's just the standard component in that treatment. So I won't mention it again. Okay. It's always going to be there.
All right.
So in the standard treatment is called VCD, and that is bortezomib is also known as Velcade.
Okay, that sounds easier to say.
That's why it's called VCD. I have
see.
a problem saying this because I have a cold sore right now.
Oh,
not a cold sore. I bit my lip.
Oh no!
So I may
canker sore or something.
Yeah, canker sore. I may be stumbling with my pronunciations.
Okay, we can all say Velcade.
Velcade
That's
is
much
nice.
easier.
Yes. So these drugs are called proteasome inhibitors, and this is the first milestone we've made with multiple myeloma, is adding these to the treatment protocols. And so the bortezomib, I think, affects the 26S proteasome. And then there's a new drug called carfilzomib. Carfilzomib. It's a proteasome inhibitor, and it targets a different proteasome, I believe the 20S proteasome. And so what happens by targeting these proteasomes? So proteasomes break down what's called polyubiquinated proteins. So they're kind of like the garbage disposals in your sink, these proteasomes. They break down, used proteins and things circulating in the blood. Okay. And as you know, the biggest problem with multiple myeloma is having all of this junk floating around. So these drugs inhibit this process of these proteasomes from breaking down this extra stuff. And what that does is it ends up the cancer cells get a buildup of these polyubiquinated proteins, and they die from it.
Oh, it's kind of counterintuitive.
It is. It's like, it's like leaving the garbage to build up in a certain area to kill the rats.
Got it. Wow.
And so the result is apoptosis. So that's how those proteasome inhibitors actually work.
How does it affect the rest of the body while this is
Well,
happening?
the cancer cells, the multiple myeloma cells, are going to be more susceptible because they're producing a mass amount of these useless proteins, and they're doing it 24/7.
Oh.
So it's going to affect them much more than other cells. So these drugs work quite well. So that was the first development in multiple myeloma. And then, of course, they came into the thalidomide derivatives. The one that works really well now is pomalidomide. So the VCD, the Velcade, cyclophosphamide, and dexamethasone has been fairly standard since I think about early 2000s, 2004, 2006, depending on which country you're in. Recently, they've switched it up and added thalidomide, and they call that VTD. VTD came out in about 2004.
Okay.
And so VTD is much better than VCD. So for overall response rates in patients, I believe VTD gives you a response rate of about 92, 93% versus 83 for VCD, which is so you're replacing the old chemotherapy drug cyclophosphamide with the thalidomide.
Got it.
And so you have less side effects. And so then, of course, carfilzomib came along, and that's a better drug than bortezomib. So that's the second generation of it. And then the third generation of the thalidomide derivatives is pomalidomide. And so that's really improved things.
And when did that come about?
Oh, quite a few years ago.
Okay, so about 2004 as well? That part of it?
No, I don't quite recall.
Not quite.
It was probably...
Since that's the third generation.
I don't know.
Okay.
I'm not sure.
All right.
I'm going to have to look that up.
The reason I'm asking that for folks at home is because one of the points we like to make when we get a chance to talk to someone with cancer is that there's new treatments coming out all the time.
Yes.
Alex just talked about, quite a difference in outcome for people just over the span of even 4 years, depending on whether they're getting what was standard.
Try a few months.
It's true.
It's pretty crazy these days.
It really is.
So now let's get into the latest and the best.
Okay.
September.
All right.
2019.
Woo, that is very latest.
FDA approved a new drug called daratumumab. Okay. This is a monoclonal antibody that, and this is a new addition for multiple myeloma, is targeting a cell surface protein called CD38.
Okay.
And so when you target CD38, it's preferentially expressed in multiple myeloma cells. When you target this and you add that to the standards, such as VTD, the new standard that is, not VCD, but right. VTD. I think they may still use VCD in Canada. I'm not 100% sure, but I have heard of.
Again, you can petition, even if you're in Canada or other countries, you can advocate for different treatments and stuff.
So, FDA approved that because of the trial was just working so well.
Wow.
And so when they added this drug, this daratumumab,
okay,
this CD38 inhibitor, when they added that in newly diagnosed patients that were eligible for stem cell transplants, they got a 53% reduction in death, which is really significant. Very, very significant.
Wow, I can see why they approved this.
Yeah, so now you have Velcade, thalidomide, Dex, and daratumumab. So it's got D-VTD.
Okay.
And so 53% reduction compared to VTD alone. So just adding that one drug. So targeting the CD38 axis is really, the new way to go. So, all patients should get that. And then just recently, a new drug called selinexor. It was newly FDA approved. I'm not sure if it's been approved for prime time yet, or if it's just been given, a designation. But that's another CD38 monoclonal antibody, and that is, works similar to daratumumab. So we have a couple of different players there, and we'll probably see a lot more.
You mean different pharmaceutical companies have developed something that works on that same. Now, tell me again, CD38, is that a chromosome? Is that a gene?
No, it's a protein.
It's a protein.
Yeah, it's
okay.
It's unique to, not unique, but it's preferentially expressed.
And what are these drugs doing to that protein?
So the way they work with all monoclonal antibodies, they work in a similar manner. Now, we don't entirely understand how they work. And it gets very complicated quickly. But what they do is they bind onto that. So they bind onto that, and they're large molecules. And then when they bind onto this, they, all of a sudden the immune system goes, hey, what's that big piece of junk on the outside of that cell? That's not supposed to be there. Let's just destroy the whole thing. So it's called antibody or cytotoxic mediated targeting.
Okay.
But basically, that's one of the processes that we believe the way these drugs work.
So it potentially just forces the immune system to notice what's going on.
Yeah.
Excellent. Wow.
One of the processes, and also having this drug attached to the CD38 receptor obviously is going to prevent it from functioning.
Mm-hmm.
So now its ligand can't bind, so you get what's called steric hindrance.
Which is?
Steric hindrance is if you go to park in a parking lot and you have a designated parking spot and you go in there and there's a truck in your parking spot, you can't park in there.
Damn.
So you have to, that's a hindrance.
Got it.
That's steric
and
hindrance.
we want to hinder these things.
Yes, we
okay.
do. Yes.
Wow. So adding this daratumumab
or selinexor.
Or selinexor, I couldn't pronounce that one with confidence, has already massively reduced death in these multiple myeloma patients.
Mm-hmm.
Wow, that's exciting.
And they're using it in first line, newly diagnosed.
Excellent. Now, who are they? Where is this happening? Is this like in one, like for example, is it like Mayo or MD Anderson, or is it kind of nationwide in a particular country, or is it just recommended?
Well, I think all of these clinical trials are international.
International.
Yeah, all clinical trials these days are international.
So it's recommended for first line treatment.
That's a sticky question.
Oh, so sticky.
Well, it depends on where you are.
Okay.
Depends on the hospital.
What
depends
I'm saying
on
is
many
the
factors.
study and the FDA in approving this treatment are saying you could use it and probably should for first line, whether certain governments are picking that up or certain provinces are picking that up or not.
FDA approval means you should use it.
Okay, so point is, there's a study out there that you could show your oncologist that says, hey, look, these peer-reviewed scientists and the FDA are saying this should be first line.
Well, if the FDA is saying you should use it, you should use it.
Mm-hmm.
I mean, that's a given. They're pretty conservative. Mm-hmm. And they don't like to approve things very often. So so if the FDA is saying that, there's undisputable proof that it's going to be beneficial.
Mm-hmm. That's great news.
Yeah.
Wow. Okay. Anything else you want to tell us about
this? No,
I think
that pretty well sums it up.
Okay. That's actually really far better news than I thought I was going to hear about this disease and the current research. So summing it up, we have standard diagnostic protocol or assessment protocol, which is that CRAB, which we want to add some genetic testing to see if you're one of those high-risk patients, because that can then expedite your treatment. It can and make your oncologist provide you with treatment faster or help them to have more confidence that they should.
Well, even if you're low risk, I would get treatment.
I understand. And then there's the Mayo Clinic process of the 20-20, which you want to make sure that your doctor is also applying to you to determine how and when to treat you. And there's this new DVTD treatment protocol that is saving lives in ginormous proportions.
Well, I think the best way to look at this is look at the targets of multiple myeloma. So you have proteasome inhibitors, and there's going to be better and newer drugs. Carfilzomib is already one of those. And there's going to be increases in that area. So companies are going to develop better proteasome inhibitors. Then there's the thalidomide derivatives. We have 3 of them right now, and that's another target.
They keep refining that.
And they keep refining that. And then there's the CD38 inhibitors. And so there's going to be just a bunch of different players in all 3 classes. So the trick to do it is, if I had multiple myeloma, what I would do is I'd find out the best proteasome inhibitor. I would find out the best version, which is probably pomalidomide, of the thalidomide derivatives. And then I would look into the best CD38 monoclonal antibodies and just make my own custom panel. Pick the best of each. So I'll take that and new CD38 inhibitor. I'll take that one. Yes.
That might sound like a tall order, which is why Alex is here.
Well, it's important to consider that when these drugs come out, the drug companies often provide the drug for free. They often, there's this grace period where they're saying, hey, we'll give this drug to anybody.
Because they want more people on it to
Exactly.
prove how well
And
it works.
exactly. And they want to show the medical systems, hey, we've got this great new drug that works really well. So there's opportunities above and beyond what your local cancer agency is offering to make these combinations yourself. We do it all the time. We'll pick the best of drug A, the best of drug C, and the best of drug D. Even if those drugs are not approved together, we know based on defined mechanisms that there's an incredibly high chance each one of those drugs is going to be incredibly beneficial. And while they haven't been tested in that exact combo, very rarely do we see that protocol or that process not working much better.
And we find increasingly over the 10 plus years we've been doing this work that because oncologists are increasingly understanding the value of genetic testing and how rapidly the research is progressing and how rapidly new treatments are coming onto the market, we find that even if they're offering you a certain treatment, might be old standard, they are increasingly open-minded to these kinds of create your own combo based on your genetics and what your risk is. So just because your oncologist has said this is what we have to offer you does not mean that if you were to present them with a little more information that they would be closed to helping you to access those treatments. In fact, we find oncologists again are increasingly supportive, but they need the evidence. You have to often take it upon yourself to get the genetic testing, to get the added data, and to provide them with the studies and the proof. And that's what Alex and his team do. Yeah, they just do all the research, gather all the tests for you, put together a report, deliver that to you, and then also to your oncologist in consultation so that they have confidence with what's being recommended if it's different. And you're not only helping yourself, but that's helping your oncologist to more rapidly assimilate this new technology, and it really benefits a lot of other people too.
Yeah, and we had I can think of a great example of that, and we get this a lot, but just a very recent example is a patient was given a type of drug called a platin, and this drug, they were given cisplatin. There's actually another class of the drug called carboplatin, and in Canada, for some reason, they were getting this combination and cisplatin was being used, whereas in the States, they typically do the same combination, but with carboplatin. And in this particular case, the patient was saying, I'm having a tough time with cisplatin. And cisplatin is, it's a harder drug to tolerate, and it can cause kidney damage, whereas carboplatin doesn't have the same side effects. And so obviously the Canadian doctors were saying, well, cisplatin is a better drug. They were told, obviously, that cisplatin, works better than carboplatin for this condition. And that was true. There was a study many years ago that showed that cisplatin does work better, but it has more side effects. And so what we did was we did some updated research for the patient, and we found that on a huge meta-analysis, the actual difference in survival of those two drugs was 2 weeks.
Whoa.
So while the doctors knew that cisplatin worked better, they didn't have the information. And this is where we get back to the beginning of our show here today, is always ask for the data. Because a lot of times the doctor hasn't looked at the data. They've assumed that the college is telling them accurate information. And, a 2-week difference in a drug.
For all those side effects.
And also, I believe the hospital visit for people on cisplatin, don't quote me, I believe it was about 43%. And with carboplatin, it was down to like 38%. So, there was a difference of like 3 or 4% roughly in hospital visits, but that's 3 or 4 people over 100, that could greatly reduce the cost only for a 2-week benefit. And so the patient said, okay, well, I want to be on the best. When they found that information out, they said, well, why am I on this drug with much harder side effects, potential for kidney damage, and potential for more hospital visits for only a 2-week benefit? So once again, the data, the scientific data is everything. You can't go with opinions. Your doctor may know that cisplatin is better, but maybe they don't know how much longer or if it's worth it.
Or like how it's better.
How it's better.
It's 2 weeks
so you
more
need to
survival,
ask.
but
So
all
if
the
your doctor
downsides.
says, oh, we're giving you this drug, it's better, show me the data. Show me
And what
what
else
the
is
difference is,
possible.
and let me make that decision. You know,
Yeah.
I may want to go with less side effects and have a
Mhm.
better quality of life.
Oh, if we're talking about a
You know, for
couple
2
of
weeks. Yeah, exactly.
Mhm.
So there's
Mhm.
many examples like that.
Mhm.
We see examples like that every day.
Mhm. Yeah.
You know,
And you have to keep in mind your oncologist is seeing, 70 to 100
yeah,
patients a week.
yeah, at least.
And they really just don't have the time to look into the current data
Yeah,
for every patient.
yeah,
As you've heard in this talk alone today, there's new studies coming out all the time, like this one that just came out in September,
hmm
like just a few
yeah,
weeks ago.
exactly.
It's showing
It's hard to
incredible
keep up with
benefits.
it.
Yes, that's right. Yeah. So there's a lot more that can be done.
Always,
Yeah,
always.
there is. We're never at a loss to provide some benefit.
No, I
No.
don't think we've ever had to turn away a patient yet.
Nope. Mhm.
One case, there was one case many, many years back where we had a patient and we had the genetic information and there wasn't really anything for that patient. I think there was no genetic markers on them.
Mm-hmm.
So
Mm-hmm.
very rare.
Yeah, that is. Yeah.
And, you know, the power of information in your treatment is everything.
Mm-hmm.
You know, don't go with opinions, go with the science.
Mm-hmm. And we've talked a lot about, getting genetic testing and, the kind of the early diagnostic process. But, I think it's important to add that we often have people coming to us who have gone through all the standard treatments without that type of diagnostic, without genetic testing or PET-CT imaging. And their disease has progressed. They're now stage 4 and they come to us and we're still able with genetic testing and with proper imaging to provide them with great relief and at times remission.
Yeah.
Mm-hmm.
Yes.
Yeah. So never too late.
Yes.
Mm-hmm.
And if your doctor tells you you have a low risk disease and, you know, it's not going to kill you and you have no worries and just to sit back and live your life, you know, and they haven't done any genetic testing and they haven't done proper diagnostics and they haven't done PET-CT, get a new doctor.
Yeah. Or, I mean, yes, I appreciate why you say that. But again, in my experience, Alex is on the research side and I'm kind of liaising with doctors and clients more. And I really have noticed a huge increase in the openness of oncologists to evidence when you present them with sound evidence. Yes. But you must understand, from their perspective, sound evidence needs to be proper FDA approved testing, like good genetic testing panels like we've talked about today, FDA approved treatments.
Yes, definitely.
They can't be supportive of treatments that don't have proper backup. No. It's just, they'll lose their license for that. So that's not an option.
They're not effective. You wouldn't want a doctor that recommends that.
No. So most doctors are open to good scientific data when you present them with it. And I want you to remember that and also what Alex shared today about what the possibilities and the great increase in survival rates that are happening. And we talked about just one type of cancer today, but we see that truly across the board. There's new surgical techniques and new treatments coming out literally all the time.
Yeah, it's incredible.
It really is.
Brave new horizons.
So don't despair. Just make sure you get all the evidence you can and that you get the right treatments for you.
Exactly.
So we'll be back next week with another episode of Ask Alex. Thanks for joining us this week. If you have any questions at all about your own cancer care or anything we said today, it might have been a little confusing at times. There's a lot of data Alex was sharing today. Please just post in the comments below. Let us know how we can help you. Thanks for joining us. Bye.
Thank you for watching Ketome TV. Subscribe below and stay informed.